an original.
From Story Studio Network.
I'm Tom Hoppe, and I'm your host of the Most Painful Podcast. On our last episode, we spoke to Dr. Jeffrey Mogul about preclinical research on sex and gender using laboratory mice and how it helps to understand the differences with chronic pain between male and female mice, which in turn will help with clinical trials. So lots of good information on this episode. If you missed it, you can listen to it on our Spotify and Apple feed. And remember to subscribe and hit the like button to get the most up-to-date episodes. In past episodes, we've discussed the connection between mental health and chronic pain. Today, I'm joined by Dr. Karapareddy, who is a psychiatrist involved in brainstem health for veterans, first responders, and other patients. And he's going to talk about chronic pain, PTSD, neuroplasticity, and the use of neuromodulation to help with these conditions. Venu, welcome to the show.
Thank you, Tom. Thank you for having me today.
So maybe we could start by just doing a quick overview of PTSD and neuroplasticity and how that kind of ties together.
Right. As you mentioned earlier, Tom, we're talking about chronic pain, PTSD, and other mental health issues. And post-traumatic stress disorder is not a one single condition. When you talk about post-traumatic stress, we're talking about a disorder. Disorder in clinical terminology means there's a number of symptoms put together. Those who are struggling with PTSD not only have nightmares, they also have a lot of other sort of challenges such as avoidance behaviors. They also present with flashbacks. They also present with hypervigilance. And significant aspect of PTSD is also personality changes, especially the veterans who have a chronic post-traumatic stress disorder symptoms. They initially start presenting with significant personality changes, whether we are talking about irritability, isolating themselves, having emotional regulation issues. So PTSD is not sort of a one condition. It's sort of a bag of number of symptoms. So now coming to the neuroplasticity. And neuroplasticity is very much an interesting terminology. And the concept of neuroplasticity has significantly changed in the last decade or two. Now we know the brain can change, brain can improve with certain positive things that can be done over a period of time. When you talk about neuroplasticity, there is a good neuroplasticity, there is a bad neuroplasticity. So let's talk about, as you mentioned earlier, what is the connection between PTSD and the neuroplasticity, right? If you see our brain as a field, a trial, wherein those with PTSD, they keep thinking about certain things over and over again. They keep thinking about having some flashbacks. And we're talking about a trial wherein if they keep doing the same thing again and again and again, those brain pathways get stronger and stronger. So that's why people with PTSD, sometimes they have this guilt feeling. They keep reliving some of the past. By doing so, certain trials within the brain gets very, very strong. So in a way, here we are talking about negative sort of a bad side of neuroplasticity that can be seen in PTSD, depression, or other conditions. And now let's talk about a good side of neuroplasticity. There are certain things that can be done to modify, again, these sort of trials or pathways, try to develop a positive pathways within the brain. A lot of things can be done. For example, having a therapy, doing certain therapies every day, like a cognitive processing therapy, or some of the EMDR, or some of the treatments we typically use for PTSD. What they tend to do is, over a period of time, they actually create a positive sort of networks within the brain, which they in fact affect by creating that positive, good neuroplasticity. And the similar way, so doing so good neuroplasticity, then that's going to modify the brain pathways, which helps to deal with the PTSD symptoms better. And over a period of time, the trauma, stress, or some of the brain pathways are more modified to have a better sort of outputs compared to without these treatments. And again, some of the medication can help to modify these pathways. But here we are talking about a newer ways of how we can actually generate this positive, good neuroplasticity. Like, we can repair the brain and help to rewire the brain or heal the brain.
That's a lot. I mean, that's a lot to unpack. And I got a lot of questions on it. But when you're looking at the bad neuroplasticity, I mean, and you got the good neuroplasticity, and that comes from trauma. When we're talking about, let's talk about veterans. I think first responders are in a different category, perhaps. Yeah. But when we talk about the rewiring of, and I'm going to ask this, is this a rewiring of the brain when you have someone who joins the military and they go through basic training and there are learned behaviors that become very normal in life that they are not aware of when they release from the service? And that can cause. So an example I always use, just to give some context, is in the military, if you're late, there's a very severe consequence for being late. And so you're constantly taught that you have to be on time. I know veterans, myself included, when you get out of the service, if we're not 15 minutes early, we actually have a physical reaction because there's always been a negative consequence to being late in the service. So now when you get out, you have this reaction, and we're not aware of why that reaction's happening. We just know that we're 15 minutes late. Does that make sense? Like, we don't know what we don't know. Is that a rewiring of the brain? Hopefully I asked the question properly, but.
Yeah. So you're totally right, Tom, because when you're in military, you are, we're talking about these habit forming behaviors. Most of the veterans I have came across, they have not actually left the military, they more or less have developed this very much ingrained sort of a pathways within the part of their brain, like, having that structure, having that routine, having all sort of the discipline in the military. So when they come back in the real world, right, they still have this sort of the innate sort of a mechanism within the part of the brain that can be explained by the pathways we are talking about, the neuroplasticity. So that's sort of a pathways they developed when they were within sort of in the military.
And so now, if someone is struggling with PTSD from a traumatic event, and then they're also leaving the service having these behaviors that, we don't know what we don't know, and we're not aware of them because they've just been normal to us, how does that combination impact the rehabilitation, right, both for traumatic and also the readjustment back into society?
Typically, some of the classic symptoms of PTSD we talk about is reliving experiences, right? They actually never left the war zone or where they experienced the trauma, whether it's abroad or they keep reliving, right? That means that over a period of number of years, these pathways becomes very, very chronic in the brain, right? And even after they leave the military, if they don't get right help and the support, these pathways, they keep reliving as if they're back in the fields, in the trials. And that's what the symptoms keep sort of triggering, even in the real world, right? Whether, having the false alarm when they're outside, when everything is perceived as a danger, everything is perceived as something coming towards them, right? That way we can explain some of the PTSD symptoms with the bad neuroplasticity we're talking about.
Because somebody who doesn't have PTSD and they are leaving the service, is there a way with what you do? I mean, so they don't have PTSD, but they're struggling with the readjustment. Mm-hmm. Does that in itself create some challenges, I guess, leaving from one society going into another? Because like you said, their brain's been wired to be in the service, and now they're leaving that service and going back into the civilian world. Even if they don't have PTSD, are you seeing patients that are struggling with that? What's the right word? Where it's fixed in your brain, right? Those habit-forming behaviors are fixed in the brain. Do they struggle as well? And is there something, do you run into patients like that?
Absolutely. That's why the transition, there's so much of talk about transition from military life to a civilian life, right? When you're adopted for whatever, a decade, 2 decades, or 3 decades in certain way, you have been doing things, and you no longer have that structure, routine, because your brain and your behavior is adopted to that, right? That's why people tend to struggle. and whether do we want to, pathologize the sort of behaviors, or is it something maybe more looking at how the brain has adopted to their previous lifestyle, what needs to be done for them to have a better adjustment into the civilian life. I think it's very important to understand some of this, the military culture and the life, so that they can be helped to adopt. And people who struggle to adopt do tend to later years tend to struggle with some mental health issues, and that may well be a stress disorder, which we typically tend to call it as an adjustment disorder. It's typically the challenges in adjusting to certain changes in their life, and that again can be explained to some extent by some of the brain mechanisms and some of the habit forming behaviors which happen over a period of time, and how easily somebody can adapt to changes in their environment or in their life, right? So that can also negatively impact somebody's psychological health. Not necessarily PTSD, but that can also lead to depression, that can also lead to certain anxiety conditions, and which I have seen quite a lot.
And that in turn will impact chronic pain as well.
Absolutely. Any form of mental health has a negative impact of chronic pain because there is clearly a bidirectional relationship between chronic pain and mental health, whether it's a stress, anxiety, depression, or PTSD.
Okay, well, thank you for that. I was just curious because we've seen that in the research where, veterans will act in a certain way without knowing it. And I've always said to veterans, we're the ones who've been removed from society and have changed. We're the ones who are going back again. So that's very helpful. When you talk about neuromodulation, maybe you could touch a little bit on, or touch a lot on that, I guess, and what that is and how that can help.
Right. The neuromodulation is basically what we are doing with neuromodulation. There are different techniques of neuromodulation. Basically, we are trying to stimulate the part of the brain in a way to rewire the brain circuits, as you're very well known from some of your topics in your podcast. A lot of people spoke brain as a billions of neurons within it. It's like a big sort of electrical field, the brain itself, and it is connected. There's a lot of chemicals within the brain, right? And then so what we're doing with the neuromodulation is we're trying to modulate the neurons. The brain, the basic cell within the part of the brain is neurons, and when the group of neurons join together, they form a structure, and each structure, certain different structures within the brain are connected with the neuronal pathways. So anything can go wrong anywhere in these billions of brain pathways. And what we know so far, the certain brain pathways or structures are more impacted compared to other structures in chronic pain and other mental health issues. What we're trying to do is with the neuromodulation is we are very much trying to target very specific parts of the brain in a way to rewire the brain, to restart the brain so that it becomes more stabler, to create a long-term healing. So one of the neuromodulation techniques we tend to use in our clinics is called transcranial magnetic stimulation. I know it sounds like a very long word. I will just break it into smaller sort of pieces. I'll come to that in a minute. The other neuromodulation techniques could be, the various other things. Electric convulsion therapy is one of the neuromodulation technique as well. I know it's a quite intense therapy that happens in hospitals where people is given for severe depression. And there are other sort of a transcortical stimulation of the brain, which is a very low voltage electricity is given to the brain to help with depression or chronic pain and other conditions. But today I'll be focusing mainly on transcranial magnetic stimulation. Basically, what we are doing in TMS, transcranial magnetic stimulation, is that we are sending the pulses, magnetic pulses, to a very specific parts of the brain, depending on what condition we are trying to target, whether it's a depression or whether it's chronic pain, PTSD, or someone with concurrent chronic pain, depression, and PTSD. By doing so, we are delivering a very much targeted magnetic pulses to this part of the brain through a magnetic coils. There are different types of magnetic coil. They're typically, in our practice, we tend to use something called figure 8 or figure H magnetic coils. What these coils do is they send a very specific pulses at a very specific frequency to a part of the brain where we tend to map the part of the brain where to give those pulses. By giving those pulses at certain times, it could be like so many pulses at given point in time. Typically, some of these pulses can be given at 3 minutes, 5 minutes duration, or 19 to 20 minutes duration, depending on the clinician and the assessment and everything. By doing so, what we are doing is we are modifying or restarting the specific part of the brain from malfunctioning to functioning normally. And that's why we tend to see outcomes, and we create a neuroplasticity in this part of the brain. Some of these treatments have changed quite drastically in the last sort of a decade or so, wherein in some of the institutions, people are actually able to visualize these parts of the brain through MRI scans, and in a live, they're able to see what's happening to this part of the brain when they're stimulating, and they're able to show that clearly there are positive changes are happening within the part of the brain.
So when you talk about conditions for the brain, is it like a known condition is this certain part of the brain, or is each individual patient's brain mapped out for what they are doing? Or has research shown like depression would be here, anxiety would be this, or how do you know exactly what to target on the brain or where?
Yes, yeah. So again, it depends on, let's say somebody comes to my clinic with a major depressive disorder. So we typically tend to target a very specific part of which we in a prefrontal cortex of the brain, which is like a part of the brain which is more of which maintains our executive functioning and clarity in thinking. So this part of the brain, there's a very specific part of prefrontal cortex called dorsolateral prefrontal cortex we tend to target for depressive disorder. Let's say somebody comes with anxiety, we tend to target on the right side of the brain. And again, the protocols we tend to use for anxiety is slightly different for protocols we tend to use for depressive disorder. And let's say somebody comes for PTSD. Again, PTSD itself is not a single condition. Quite often those with PTSD have significant depression as well as anxiety disorder. Depending on severity of depression, we either go for left side of the brain, which is prefrontal cortex, left side of the brain. If there's significant anxiety with PTSD symptoms, we can also target the right side of the brain. So it's a quite precise in a way that where we target, and we tend to map out the brain even before we target. So it tends to be very much individualized to person where these parts of the brain structures are located. And so that's why it's a very much precision, non-invasive technique.
And what's the research? How much research has been done on this technique, and what are the outcomes of it?
Absolutely. So there's been quite a significant research, especially in the last 2 decades or so. These are especially in the field of major depressive disorder. And it's been recommended by FDA for depression, recommended for depression and anxiety, as well as obsessive compulsive disorder, and the offline treatment for PTSD, chronic pain, and other conditions. And a lot of Canadian guidelines also recommends transcranial magnetic stimulation for major depression.
So a person goes through the treatment. Is it long lasting? Does it have to be redone every so often? What kind of outcomes are happening with this treatment?
So the typical process timelines is initially when we started doing it a few years ago, typically we need to give anywhere between 20 to 30 sessions in order to generate that neuroplasticity. In a standard pathways, we used to individuals to come almost 5 days a week to the clinic for 4 to 6 weeks in order to have these protocols. But in the recent sort of last few years, we have something called an accelerated protocols, wherein we are able to give these pulses, magnetic stimulation, multiple times in a day. That would mean that the treatments we used to typically give over 6 weeks, now we can actually bring in an individual and give them over 5 days. That would mean that what we are seeing in your clinics and literature has strongly sort of shown that day 2, day 3, we are actually seeing benefits. So this is like amazing. In my career as a psychiatrist, I have never seen that impact, like somebody is getting better within day 2 or day 3, either from depression or some of their sleep or some of the PTSD symptoms. Even people have reported improvement in their chronic pain levels. Obviously, as you know, that there is such a bidirectional relationship between chronic pain, mood, and other sort of conditions. So improvement in mood is also helping with their chronic pain.
And what's the the longevity of this? How long are you finding? So they come in for 5 days to do their treatments, but how long is that lasting? Or do you even have enough information to make that assessment?
So we know about treatment protocols, how often we need to give treatment, how long we need to give treatment. With regards to the maintenance, like how long some of these effects. So we have individuals who probably have been sort of clear of symptoms for 6 months, 12 months, or even longer. But certain individuals are coming back for more sessions after a period of a gap. So that's why the maintenance is very, very important. So what we typically do with maintenance therapy in order to keep the recovery going is that we tend to typically taper down the treatments, right? Giving every day to few times a week and then gradually tapering down to once a month. I typically tend to recommend people at least keeping once a month over a long period of time so that A, the treatment continues, B, is that they are being monitored regularly to support their long-term recovery.
And is there other therapies that are done in conjunction with this to reinforce the neuroplasticity or the behavior changes?
Absolutely. So any treatments we talk about, especially those with concurrent issues, should not be on their own. It has to be a whole structure of biopsychosocial pathways needs to be considered, because what we are not dealing with one single condition here. So it's a very important, the psychotherapy and other supports are in place. And more importantly, lifestyle changes such as having a good night's sleep, diet, exercise, these are all add to the value in terms of long-term recovery.
Well, that's awesome. I mean, we're coming to the end of the show here, and it's just interesting to hear. For me, on this program is the first time I've heard of bad neuroplasticity. So I think we always think about the positive changes in the brain, and which makes sense from what you're saying. You can form bad habits as well. So thank you for your time for being on the show, Venue. Appreciate it.
Thank you, Tom. Thanks for having me here today.
Thank you. For feedback about the show or more information on chronic pain, you can visit our website, veteranschronicpain.ca, or follow us on Facebook and X at Chronic Pain COE and on Instagram at chronicpain_COE. Thank you again. And for the audience, stay safe and keep the hope alive.
The Most Painful Podcast is produced for the Chronic Pain Center of Excellence by Story Studio Network.